Hi and welcome everyone. I'm Dr. Vanessa Pittel, the clinical head at Ace Alzheimer Center, Barcelona. As the host of this session, it's my pleasure to introduce the third and final session of this online summit, organized by Ace Alzheimer Center, Barcelona with the support of Grifols. At Ace, we always had a clear purpose, to bring the Alzheimer diagnosis, treatment and research to a whole new level. Today, we are a renowned organization all over the world with a team of 100 professionals. Since 1996, we have diagnosed over 30,000 people, collected over 18 biologic samples, and led more than 150 clinical trials. This, along with the national and international research project that we have led, has allowed us to become more and more present in scientific highlights at the last decade. And I'm proud to say there is so much more to come. Now, let me introduce the chair that we will moderate in this session. Dr. Chris Butler. Dr. Chris Butler is the reader in dementia research at Imperial College London and a consultant neurologist. His research project studies how cognitive impairment is related to changes in brain structures and function, and applies this knowledge to develop new diagnostics and therapies for different neurodegenerative diseases. Welcome, Dr. Butler, and thank you for moderating this session.
Thank you very much for this kind introduction, Dr. Pittel. I'd like to thank the organization for inviting me to moderate this last session of the ATHE Global Research Summit 2023, focusing on innovative therapies. As you will be well aware, attempts at pharmacological treatment of Alzheimer's disease and other dementias have a long and somewhat checkered history. Whilst we can now reduce the amyloid burden in the brain, improving the cognition and daily function of people with Alzheimer's disease has been considerably harder to achieve. Impairments in memory and attention and language, executive function and perception relate to changes in neuronal activity across large-scale networks in the brain. Research in recent years has demonstrated that techniques of non-invasive brain stimulation, especially using transcranial magnetic stimulation or electrical stimulation, can potentially be used to normalize activity within these brain networks and correct some of the cognitive consequences of Alzheimer's disease. I suspect that in future, a more complex approach will be required. We'll prescribe individually tailored, multi-component programs of therapy to our patients, with medication, brain stimulation, and environmental and social interventions. Today, we will hear from two renowned scientists at the forefront of research in the application of non-invasive brain stimulation to neurodegenerative diseases. During the session, you can send your questions and comments to the speakers through the chat, but we will leave it until the end of the session to answer them. So our first speaker of the day is Dr. Alvaro Pascual-Leone, one of the world's best-known scientists in the field of neuromodulation. He's a professor of neurology at Harvard Medical School and medical director at the Diana and Sidney Walk Center for Memory Health, Hebrew Senior Life. His research combines neuroimaging and a range of non-invasive brain stimulation techniques to explore and modulate brain plasticity and behavior. As a clinician, he has a particular interest in developing interventions to prevent and overcome the effects of neurodegenerative disease. Dr. Pascual-Leone, we are delighted that you've agreed to speak to us today on applications of non-invasive brain stimulation in patients with Alzheimer's disease and related disorders. Thank you very much.
It is a pleasure to be here. Thank you for having me as part of this exciting symposium. Thank you to the Fundación ACE. My talk is about non-invasive brain stimulation in dementia, specifically in Alzheimer's disease-related dementia. Before I get going, let me share my disclosures. I'm a member of scientific advisory boards of a number of companies. I'm a co-founder and chief medical officer of Linus Health and of TI Solutions. The latter I will mention briefly at the end of my talk, so please take this disclosure seriously. And I'm a listed inventor in a number of patents, some of which are related to the topic of this talk. The focus of my talk is on non-invasive brain stimulation, and there are a number of different methods for non-invasive brain stimulation. In fact, the list of methods is rapidly expanding, including electromagnetic and magnetic methods, but also light-based interventions, ultrasound, and multisensory stimulation. Cognito, one of the multisensory stimulation companies, the leader in that field, is currently conducting a very exciting phase 3 pre-market approval trial for the FDA. I'm going to focus on the electromagnetic methods, and specifically on transcranial magnetic stimulation and transcranial current stimulation. The reason to focus on those is because those are the techniques where most of the work to date has been done, and they can serve both to illustrate the potential, to translate into clinic, but also to highlight the challenges in the development of other methods. I'm going to try to cover two specific areas. One is the use of non-invasive brain stimulation to promote insights into the pathophysiology of Alzheimer's disease-related dementias. And the second, to talk about therapeutic interventions, attempts to improve comorbidities, for example, depression, but also targeted approaches to improve cognitive abilities. Broadly speaking, we can think of the healthy brain as having a certain structure that gives rise to a certain pattern of brain function, can be characterized with spatiotemporal signatures, each one of which maps onto a given emotion, a thought, or behavior. In the setting of disease, a stressor, an injury, an insult, or a neurodegenerative process will lead to a modification of brain structure because of the pathology, and critically will lead to alterations in spatiotemporal signatures, and those altered spatiotemporal signatures are the immediate cause of symptoms or disabilities. Transcranial methods of stimulation allow us to characterize the spatiotemporal signatures and to modify them in order to understand causal relationships between them and symptoms and disabilities. There are a number of methods, a number of techniques of non-invasive brain stimulation that can be explored to try to identify the alterations in spatiotemporal signatures that give rise to symptoms and disabilities in different dementing illnesses. In this summary review paper from a couple of years ago, Di Lazzaro led a group of experts that showed that a number of different methods, motor threshold methods, methods of characterizing plasticity mechanisms, pair pulse stimulation to characterize intracortical excitability, they can provide critical insights into the pathophysiology of these dementing neurodegenerative disorders, and perhaps particularly exciting, they can differentiate between them. They can differentiate between Alzheimer's disease and FTD or diffuse Lewy body. One of the things we've come to learn is that in neurodegenerative processes, broadly speaking, ADRDs, there is an alteration in cortical excitability that maps onto the severity of the disability. Over time, the brain becomes hyperexcitable. That may be a target of intervention, and it may be a pathophysiological result of the complex pathophysiology underlying these disorders. In addition to that, techniques like theta burst stimulation allow us to go beyond characterization of excitability and explore methods to characterize the adaptation of the brain to a given perturbation, effectively looking at the efficacy of the mechanisms of plasticity. We can characterize potentiation-like plasticity and depression-like plasticity, and we know, of course, that those are linked to synaptic mechanisms that get affected by, for example, amyloid oligomers. One can generate a curve of a given individual, LTP-like and LTD-like plasticity. And if we look at these mechanisms in individuals with diabetes, MCI, or Alzheimer's disease, you can see from work of Peter Fried and Stephanie Buss here that there is a prominent alteration specifically of the LTP-like plasticity mechanisms that can be seen in Alzheimer's disease-related dementia, is present already in MCI, and is present in individuals at risk for Alzheimer's disease, including those with type 2 diabetes. And in fact, the degree of alteration of LTP-like plasticity correlates with the degree of disability in learning or memory. Importantly, these type of methods are truly translatable phenotypes. In other words, one can apply them to humans, to patients, as well as healthy controls, and one can apply the exact same methods to animal models in order to identify the underlying molecular, biochemical, and physiologic mechanisms with great precision. The same alterations in plasticity I just mentioned, for example, can be demonstrated in AD models in order to develop targets of interventions. If I am allowed to shift to the therapeutic applications, let me mention that one of the first, in fact, the first approval for non-invasive brain stimulation by the Food and Drug Administration is for the treatment of depression. And of course, depression affects 60% of patients with dementias, specifically with Alzheimer's disease-related dementia. It leads to greater cognitive disability. It is often resistant to treatment. Treatment is complicated because of interactions of medications. And it is exciting that we now have at our disposal a number of devices of transcranial magnetic stimulation that have been shown to be very effective in treating depression, even medication-resistant depression, in elderly individuals responding as well as young ones, and individuals with dementia being equally helped as those without. So consider this very established application as one example of therapeutic applications of non-invasive brain stimulation in Alzheimer's disease and dementias. Beyond that, though, there is a large number of trials that have been looking at applications of non-invasive brain stimulation to different targets, as you can see on the slide, in order to improve different symptoms. The idea being that if we can target those spatial temporal signatures I was mentioning before, we can improve specific disabilities. One way to do that particularly effectively might be to combine cognitive training with brain stimulation to target a given brain network and then engage that modified brain activity pattern in a given cognitive training intervention. Neuronics is a company that pursued precisely that idea and in fact conducted a multi-center study with 130 patients of 12-week duration, and the results have been published. It was a pivotal study for the FDA. The results I'll tell you in a second, but before doing so, let me point out a very important characteristic of this intervention. The idea was to try to not simply target one cognitive dysfunction, of which there's many studies, but rather to target the many alterations of spatial temporal signatures and disabilities that these patients show. And in order to do that, the protocol included 6 different brain regions being targeted with parameters of stimulation that enhance activity, modified the spatial temporal signature alteration, and coupled it with tasks that were specific for the targeted networks. This was done on daily sessions, each daily session targeting 4 different targets over the course of 6 weeks. And importantly, when doing that, one of the things that was shown by Katie Brem and others is that one consequence of the intervention is that in the real group, not in the sham group, there was a recovery of the efficiency of the mechanisms of plasticity. So the intervention effectively improved the pathophysiology of the disease. In addition to that, it improved cognitive performance in the real group, but the degree of improvement, though statistically significant, was relatively small. And so at the end of the trial, the FDA made the argument that a mean change in the ADAS-Cog of just about 2 points, while statistically significant, was not clinically meaningful enough, and that a follow-up trial would be required to gain approval. I think that's an important take-home message that I will keep coming back to. The studies to date have been often promising, but they have failed to show a substantial effect, a clinically meaningful effect to warrant real enthusiasm, and at least for now, to not accomplish approval of these techniques. If one looks at a summary of all the studies that have been done with Sandeep Pagali, with Maria Lapid, and others that Mayo has recently put together, you can see that there is a fair number of studies. They have looked at different outcome measures, consistent with the data I just showed you. On the right side of the screen, you see the ADAS-Cog outcomes of various studies, and there is about for the most part, a 1 to 2 point improvement. Occasionally, some studies have shown a much greater improvement, but you can see that there is variability in the degree. There is consistency in the beneficial effect, but there are relatively small effect sizes. Why is that? And what can we learn from the studies today to try to improve the efficacy and have something that we can really ultimately celebrate? So let me go back to these notions I was advancing at the beginning of spatiotemporal signatures and their alteration mapping onto the symptoms and disabilities. If that is the case, if we can identify the altered spatiotemporal signature, we should be able to modify it specifically with neurophysiologic brain stimulation interventions. And in doing so, we might expect a symptomatic improvement, but if we maintain that force improvement, this force normalization, one might also be able to induce a modification of the underlying pathophysiology and ultimately a reduction of the pathophysiology. For example, in work from Lucy Brochet from a number of years ago with Christophe Michel, we were able to show, as you can see here, that in the setting of an episodic memory task, older adults show a certain pattern of activity that you see on the left, and patients with MCI or ADRD show a clear alteration of that spatiotemporal signature. We can identify the source of that spatiotemporal signature alteration that maps onto the angular gyrus, and we can then target that altered spatiotemporal signature, normalize it pathophysiologically, and when we do that, there is a rather dramatic effect on memory, on episodic memory, with a prominent improvement over the course of a 14-week intervention. And that improvement that lasts on for about 3 months, only to then slowly subside. Following on that work and building on it, Alberto Benuzzi and Barbara Boroni have completed a study on 60 patients, randomized to sham and gamma transcranial alternating current stimulation. Transcranial alternating current stimulation being a method of non-invasive brain stimulation that allows for spatially specific targeting of a given network at a specific frequency of stimulation. And what they have shown is that there is a clinical benefit in those who get real stimulation at the gamma frequency, and that is associated with a significant enhancement of that specific frequency of activity in the brain, and the degree of increase in gamma power is correlated with the degree of clinical improvement. Excitingly, this type of intervention that identifies a specific spatiotemporal signature of a specific disability and does that carefully in the setting of a laboratory intervention can then be combined with a home-based therapeutic intervention so that a specific personalized montage of stimulation and protocol of stimulation is developed and then launched to the patient's home with the support of a caregiver. Different devices, notably the one from Neuroelectrics, the StarStim home system device, allows to enable such an intervention. And Davide Capone has developed a curriculum to ensure that the caregivers are appropriately trained and therefore the intervention is appropriately conducted at home with precision and accuracy. Using that protocol to ensure quality of the intervention, Davide has completed a proof of principle sort of pilot study on patients undergoing home-based stimulation following a personalized montage targeting their spatiotemporal signature alteration that maps onto memory dysfunction. Adherence was excellent, side effects very minimal, and the results showed a clear improvement in memory index score that sustained for the taper phase. And you see the individual curves of the various subjects showing the consistency of the effects, both during the acute phase, a clear improvement, and then a maintenance of the effect with minimal number of maintenance sessions. Again, excitingly, these clinical improvements are paralleled and accounted for by changes in those spatiotemporal signatures that show a clear modification, a clear, quote, normalization to account for the clinical beneficial effects. So it allows us to develop a personalized intervention and have neurophysiologic metrics that we can follow to ensure that we're targeting the right substrate and inducing the changes that are desirable. Now, one of the exciting things about this approach is that it allows to target not only one altered spatiotemporal signature, but it can combine different patterns of stimulation, different protocols of stimulation at the same time to target more than one cognitive dysfunction. So, for example, with Brad Manner, we're involved now in an ongoing study supported by the National Institutes of Health, combining two forms of stimulation to two different brain circuits at two different patterns of oscillation to try to improve at the same time memory dysfunction, episodic memory dysfunction, and executive disability. And the results to date, very, very preliminarily, show that there is a clear, significant improvement that correlates with the degree of modification of those targets. Targeting the memory circuit improves memory, targeting the executive circuit improves executive function, but targeting both improves not only both cognitive functions, as tested in neuropsych testing, but perhaps more importantly, improves activities of daily living and well-being of the patient. I want to finish with one last thought, and that is that I've been talking to you about targeting spatiotemporal signatures with a fundamental limitation of the techniques being that their site of action is in the cortical convexity, in the cortical mantle. And yet we know that the pathology of Alzheimer's disease and many neurodegenerative disorders starts deep in the brain. So can we modify our target so that we might be able to target deeper structures selectively? Can we get to the sites of early pathology non-invasively? In order to do that, we need the stimulation to reach deeper in the brain and do so specifically. And we need to either leverage connectivity between brain areas or develop methods that have depth selectivity. One such method is called temporal interference. It was developed by Nir Grossman, along with Ed Boyden, myself, and a group of others at MIT. And in a proof of principle study in animal models, very carefully, Nir was able to show, as you see in the center of the screen, the selectivity of activation of the hippocampal structures when targeting there, that is predicated on the fact that the stimulation has essentially two beams that come together at a targeted point, and that at that point, the carrier frequencies cancel out because they're antiphase and the residual frequency of stimulation is left. In a very recent study now completed by Ines Violante, and personally impressed, we were able to transfer that approach to humans and show that there is the possibility of selectively targeting specific subfields of the hippocampus, and in doing so, not only have a normalization of an altered pattern of activity associated with a sort of memory, encoding, and recall task, but also a behavioral improvement on that encoding and recall task itself. So there is a behavioral effect that is parallel with the identifiable neurophysiological modification that is specific to subfields of the hippocampus that can be targeted selectively. Now, this is in healthy individuals. The question remains, and it's now in the process of being pursued, whether we can translate this approach to patients and have similar selectivity. But it would potentially offer the opportunity to target spatiotemporal signature alterations, not only of convexity and cortex, but also of subcortical structures, with the promise of greater efficacy and earlier therapeutic targets. So to summarize, what I've tried to show you is that non-invasive brain stimulation approaches, of which there are many, even if one focuses on the two most studied, transcranial current stimulation and transcranial magnetic stimulation, offer the promise of unique insights into the pathophysiology of neurodegenerative dementing illnesses. It allows us to identify altered spatiotemporal signatures that map onto cognitive disability. It allows us to identify the underlying pathophysiologic mechanisms, and we can translate those to animal studies to get mechanistic insights. And we can do that while at the same time deploying therapeutic interventions, helping patients, addressing their disabilities, while at the same time we continue to advance underlying insights, enabling better therapeutic trials, and adding valuable insights and tools to the therapeutic armamentarium of clinicians. Thank you very much.
Thank you very much indeed for this fantastic presentation, Dr. Pasquale Leoni. And to our audience, please remember that we will be answering all questions after the talks. Now, our second speaker is Dr. Robert Chen, Professor of Neurology at the University of Toronto and Senior Scientist at the Krembil Brain Institute. Dr. Chen's research focuses on understanding the organization and plasticity of neural networks affected by neurological diseases, and in recent years, he's been a true pioneer developing the technique of transcranial ultrasound stimulation to enable highly precise but non-invasive modulation of brain function, even within deep brain structures. Dr. Chen, thank you very much indeed for agreeing to join us today and share your thoughts on how this novel tool can be applied in patients with neurodegenerative diseases. Thank you.
Thank you very much for the invitation to this important and interesting meeting on neurodegenerative disease. My talk is on transcranial ultrasound neuromodulation and neurodegenerative diseases. I'd like to first give an introduction to ultrasound for neuromodulation. As you all know, ultrasound is sound frequency that's defined as higher than 20 kilohertz, which is the upper limit of human hearing. We all know that ultrasound is widely used in diagnostic imaging. In neurology, ultrasound has also been used for lesioning. The figure on the right showed a MRI-guided ultrasound lesioning procedure that uses over 1,000 transducers that focus the ultrasound energy to one point. And it has been approved for certain indications. For example, ultrasound phlebotomy for treatment of tremor. It's also been approved by the FDA for treatment of Parkinson's disease. Another very interesting emerging use of ultrasound is the opening of blood-brain barrier. So in this application, usually there's intravenous injection of microbubbles. And when the ultrasound is directed to a specific part of the brain, the microbubble expands and opens up the blood-brain barrier. So it is active area investigation in many neurodegenerative diseases, such as Parkinson's disease, Alzheimer's disease, and ALS, to open the blood-brain barrier that may allow delivery of large molecules or antibodies, for example, for treatment of neurodegenerative disease. However, my talk is going to focus on a different application. This is low-intensity ultrasound as a non-invasive neuromodulation. The intensity is much lower than that of the lesion and also lower than that of the blood-brain barrier. So our goal is to change brain excitability and induce brain plasticity without producing any lesion. The main advantage of non-invasive ultrasound neuromodulation compared to current ways of non-invasive neuromodulation, such as transcranial magnetic stimulation or TMS, or transcranial electrical stimulation, is that it is much more focal than the currently used method and can reach greater depth, and we can stimulate deep brain structures. This is a study we published in 2020. On the left shows the transcranial magnetic stimulation in the area that will be activated when one stimulates the motor cortex. On the right is a comparison based on simulation of the area activated by ultrasound. You can see that the area activated by ultrasound is much more focal than that of TMS. This is a study published by our group last year in brain stimulation. It's a systematic review of human studies of transcranial ultrasound neuromodulation. So in this study, we identified 32 studies. This is a summary of the studies that we identified. It's a complicated figure. I will not go through everything, but I just want to point out a few features. In the lighter color here is studies in normal subjects. The area that has been tested include motor cortex, M1, visual cortex, V1, somatosensory cortex, S1 and S2, and the thalamus. The green area is a patient with depression. So the main area that has been stimulated is the frontal lobe. The light blue is patients with epilepsy. The main area that's been tested is the mesotemporal lobe. And in this darker orange area is patients with dementia or Alzheimer's disease. So some studies have stimulated the hippocampus, the HPC. Some have the mesotemporal lobe, and also a few other areas as well. So these studies have used different techniques at different assessment. Some use concept assessment, some use clinical scales. Bottom here shows that some of the studies, many in normal subjects, also use neurophysiology assessment. However, all these studies are relatively small, and all the patient studies are small studies and generally unblinded. So there's so far no large-scale randomized control trial using ultrasound for neuromodulation. The next I'd like to address is the mechanism of ultrasound neuromodulation. So this is a review that we published with many experts in the field who know actually a lot more about ultrasound than myself. It was published in Clinical Neurophysiology last year. The mechanism ultrasound neuromodulation there is not entirely known, but there are several hypotheses. The first one is cavitation or bubble formation. So bubble formation is the mechanism thought to be involved in ultrasound in the treatment of, for example, gallstones or kidney stones. However, we don't think this is the mechanism for neuromodulation because the intensity usually required is much higher. Another potential mechanism is a temperature increase. So this is the mechanism, of course, for the thermal lesion and their thermosensitive ion channel. However, we also generally do not think that this is the mechanism for ultrasound neuromodulation. Again, because studies have shown that there's only very minimal increase in temperature. So we think that the most likely mechanism is a mechanical force. So one proposed mechanism is that the enzymes that are sequestered by lipid raft in the membrane, and with the mechanical force as a disruption, and then enzyme become released and able to interact with the substrate, and then it acts on mechanical sensitive ion channels. So several different types of ion channels has been identified in animal studies. So these are mechanical sensitive ion channels. Most of them are calcium channels, some of them are sodium channels. So we think this is probably the most likely mechanism of action of ultrasound for neuromodulation. So the next topic I'd like to address is using ultrasound stimulation to induce cortical plasticity. We think that plasticity is important because induction of plasticity or after effects, so these are effects that still persist after we finish the stimulation, is probably needed if we want to use non-invasive neuromodulation for treatment of neurological and psychiatric disorders. For example, repetitive TMS is approved for treatment of depression, and many guidelines and systematic analysis also suggest that it is useful for treating pain and stroke. And we think that it requires a after effects or plasticity effect. And in animal study, there are already several studies that show that there is a after effect of ultrasound. Example here is a study by Verhagen published in 2019. This is done in macaques or in monkeys. So this is a study inside the MRI. So the authors applied 40 seconds of ultrasound stimulation to the supplementary motor area and the frontal polar cortex. And they showed that there are changes as measured by functional MRI for more than 1 hour. So our group did a study using ultrasound on the human subject, on the human motor cortex. This is also published last year in the Annals of Neurology. In this study, we have 50 normal subjects. We targeted motor cortex. They came in for 3 visits in random order. So there are 3 different interventions. The first one we have called the theta burst ultrasound. So this is modeled after theta burst stimulation, which is widely used in hippocampal slices and in vivo animal models to induce long-term potentiation LTP plasticity. And there's also a theta burst TMS protocol. So in this theta burst ultrasound protocol, we have 20 millisecond bursts of ultrasound repeated at 5 hertz. That's why it's theta frequency, and total of 400 bursts. The total protocol duration is 80 seconds, and the actual sonication time is 8 seconds. So it's a 10% duty cycle. We compare this to another protocol we call regular ultrasound. We use 500 millisecond bursts. The reason we use 500 millisecond is that in the previous online ultrasound study, we used 500 millisecond. And we basically designed the protocol so that the total protocol duration 80 seconds and the total sonication duration is also 8 seconds. And the third intervention is sham theta burst ultrasound. And in the sham studies, we flip the ultrasound transducer so that the ultrasound is away from the scalp instead of towards the scalp. The outcome measure, we use transcranial magnetic stimulation. So this is a schematic, and many of you will be familiar with transcranial magnetic stimulation. We stimulate the motor cortex. It will activate the cortical spinal neuron indirectly, and a pulse will go through the cortical spinal tract and will record the signal in the hand muscle as a motor evoked potential, or MEP. The amplitude of this can be a measure of cortical excitability. And this is the results of the study. On the y-axis is the MEP amplitude index for cortical excitability. Before the intervention is 1, and then we measure at 5, 30, and 60 minutes after the intervention. With the theta burst ultrasound, there's an increase in cortical excitability at 5 and 30 minutes. So it lasts at least 30 minutes. It is about 40% increase in MEP amplitude. Below is the data from individual subjects. In the theta burst ultrasound, we found effects in 14 out of 15 subjects. So it's relatively consistent effect. And there is no consistent effect with either the regular ultrasound or the sham stimulation. So the next topic I'd like to address is using ultrasound neuromodulation in Parkinson's disease. So this is a study that we've done. It's not published yet. We have 20 Parkinson's disease patients and 17 age-matched controls. So they all undergo the theta burst ultrasound protocol. The Parkinson patients are studied either on medication or off medication. Off medication is 24 hours off medication, and they come in 2 visits in random order. So the baseline is shown here, the amplitude, and then 5, 30, and 60 minutes after the theta burst ultrasound. We see that in control, there's an increase in the cortical excitability. Now, I should mention that these controls are older normal subjects, where the previous study I showed you in younger normal subjects. So the extent of the increase may be slightly smaller and may take a little bit longer, but there's definitely an increase in cortical excitability in the older control subjects. In the Parkinson patient off medication, there's no change. There's no plasticity induced by the theta burst ultrasound. Whereas in the Parkinson patient on medication, there is an increase very, very similar to that of control subject. So the plasticity effect is absent in PD off medication and restored in PD on medication. We also look at the clinical effects of theta burst ultrasound. Having said that the study is not designed to look at the clinical effect because we only assess it 60 minutes after sonication. And by that time, the cortical excitability already go back to normal. We use the UPDRS, the Unified Parkinson's Rating Scale, which is standard mode for motor assessment in Parkinson's disease. We didn't show a trend, but not a significant difference in compared to baseline UPDRS to the 60 minutes after theta burst ultrasound. So lower is better for the UPDRS. However, we did find a significant improvement in the bradykinesia subscores of the UPDRS at 60 minutes after the ultrasound in the PD on medication group. We also done another study in Parkinson's disease. So in this study, we have 10 patients, and they are studied in the off medication state. What we did is we call it accelerated protocol. So the patient come in 2 visits in random order, either receive active or sham stimulation. So the protocol is that we have a baseline UPDRS scale, then we assess cortical excitability, and the intervention involved 3 sessions of the theta burst ultrasound. They are separated 30 minutes apart, so they all happen in the same day. And then we measure cortical excitability with TMS and again with UPDRS measures. And this is the results of the TMS measure, looking at amplitude, looking at cortical excitability. So the theta burst simulation again applied to the motor cortex. So here that we see after 3 sessions, the theta burst ultrasound, there is an increase in MEP amplitude in the post compared with the pre. As I mentioned previously, in the off medication state, 1 session do not have cause an increase. It appears that 3 sessions is able to cause an increase in cortical excitability. There's no change with the sham stimulation. We did not find a significant difference in terms of the motor UPDRS at the end of the 3 stimulation sessions. However, there was a trend for reduction in the rigidity score, which is shown here. The lighter blue is the active ultrasound stimulation, whereas darker blue is a sham. So the trend for reduction in rigidity score with active compared to sham theta burst ultrasound. So summarizing the finding in Parkinson's disease so far, theta burst ultrasound-induced plasticity is associated with an increase in cortical excitability in older control subjects and Parkinson's patients on medication for up to 30 minutes. And the theta burst-induced cortical plasticity is reduced in Parkinson's patients off medication and restored with dopaminergic medication. And theta burst ultrasound to motor cortex can improve bradykinesia in Parkinson's patients even after 60 minutes. And in 3 sessions of ultrasound on the same day in an accelerated protocol, we're able to induce cortical plasticity even in the off-medication state similar to controls. So the implication is we think that for future studies, we could use non-invasive theta burst ultrasound, but it will require likely multiple sessions. For example, in treatment of depression, typically like 50 sessions is used. So we think the future study could use this, but apply multiple sessions to see if there is a lasting clinical benefit. So the next topic I'd like to address is using ultrasound to target deeper brain structures. The study I showed you earlier is mainly targeting the motor cortex. The reason we started with motor cortex is that we can use TMS to measure the excitability outcome. But the main advantage of the ultrasound is that it can reach deeper targets. It is more focal than other non-invasive stimulation techniques. The area of activation is described as a cigar shape. So typically it's about 10 millimeter length, a width of about 2 to 4 millimeters. It is more focal than other non-invasive stimulation, but it's less focal, for example, than deep brain stimulation. However, one main issue of ultrasound targeting the deep area is that it is attenuated and deflected by the skull. So this is important to provide accurate simulation. We will have to use individual brain MRI or CT scan to model the skull to provide this accurate simulation. There are already several published studies in human subjects targeting the deeper brain structures. So I just want to show you one example in normal subjects. So this is a study by Kane and colleagues from UCLA. In this group, they targeted the left globus pallidus. So in the figure here, the blue area is the target without correction, whereas the red area is the target with correction of the skull attenuation. So there is a difference with and without the correction. What the authors show is that with the left globus pallidus stimulation, they have a widespread reduction in bold signal as measured by MRI. So this is the bold signal measured by MRI before and after the globus pallidus stimulation. There's also a decrease in blood flow measured by ASL, arterial spin labeling. Again, fairly widespread reduction in blood flow. There are also several small studies in human subjects in patients in deep brain area. So I'm going to show you one example. This is also studied by Kane et al. They have actually several studies in disorders of consciousness. This study is in 16 patients with acute disorders of consciousness, mainly from traumatic brain injury. So these patients undergo one session of ultrasound targeted to either the left or the right central thalamus. I should caution that this is an entirely open label study. And they show is that there is an improvement in the coma recovery scale revised after the ultrasound compared to before ultrasound. So this is, I think, indicating that the intervention to be safe, but we have to interpret the data carefully because open label study, we cannot exclude, for example, spontaneous recovery, account for some of the results. I'd like to also highlight a few studies that are ongoing in our group targeting the deep brain area. So this ongoing study, I don't actually have any results to show, but I'd like to show you the method that we're using. We have studied that we are targeting a patient with deep brain stimulation who has Parkinson's disease. So deep brain stimulation target is usually the subthalamic nucleus or the internal globus pallidus. And these patients are implanted with a relatively new DBS device called a Medtronic Percept device that we can actually record the local field potentials from the DBS electrode. So shown in A is the schematic of the study. So the ultrasound transducer is shown here, and these are trackers for a frameless steerless taxi, a brainside neural navigation system. Shown in B is the schematic of the study. So patient has a DBS electrode implanted either in the STN or the GPI. They connect to the pulse generator capable of recording local field potential, and we apply ultrasound actually to the target area. C is example of the recording. So the upper panel is the raw recording of local field potential. The lower panel is the power spectral analysis over time, showing that there is a high beta band, which is a biomarker of patients with Parkinson's disease. It is shown that beta band is elevated in people with Parkinson's disease and decreased with treatment. So in the study, we want to show is that we can accurately target these structures to take advantage of the fact that we actually have a patient with a implanted electrode in the target area, and to find stimulation parameter that will reduce the beta oscillation, which is a reliable biomarker of Parkinson's motor symptoms. So here are some preliminary results. So this is the MRI scan of a patient who has bilateral GPI DBS. You can see the arrow points to the DBS artifact. And these are simulations done. So we will put the ultrasound over the temporal bone window, which is the thinnest part of the skull. And using the simulation, we show that we can accurately target the GPI internal globus pallidus area. C here is the estimated pressure at the target area, and D is the estimated temperature rise. Temperature rise, you see, is very small, only about from 37 to roughly maybe 37.3 or 37.4 degrees. Using simulation, we can also target the even deeper structure, the peduncular-pointing nucleus. So this nucleus is interesting in the sense that it is thought to be involved in freezing of the gait in patients with Parkinson's disease, and there has been several studies that use deep brain stimulation to target the peduncular-pointing nucleus in Parkinson's disease. So we think that we can also use ultrasound to target this deep area. So the last topic I'd like to address is using ultra-neuromodulation in Alzheimer's disease. Now, there are already several studies that use deep brain stimulation in Alzheimer's disease. The most common target is the phonics, and over 100 patients has been studied. In the phase 2 study published in 2016 in 46 patients, it showed that there is increased glucose metabolism, but no significant difference in cognitive outcome. Excuse me. However, in the follow-up study published last year in Nature Communication, the same group, using more detailed MRI analysis and tractography, and they showed that stimulation of the pathway circuit, which is the phonics is part of, if one can target this area accurately, then it is associated with cognitive improvement. And the phase 3 trial of this phonics DBS is underway. And there are other DBS targets shown in this figure here, including the nucleus basalis, the ventral medial prefrontal cortex, and the hypothalamus. What I mainly want to show is that while these are targets for deep brain stimulation, is obviously invasive treatment, and all these targets can be reached using ultrasound neuromodulation. So another study in Alzheimer's disease I'd like to show is that a study that used a technique called transcranial pulse stimulation, or TPS. So these are very short ultrasound pulses. Shown in B here is the TPS compared to a conventional ultrasound neuromodulation. And in this study, the authors used this device shown in the picture here, and they targeted different cortical areas, including the dorsolateral prefrontal cortex, the default mode network, and the language network. So basically move these stimulator around to target these different cortical areas. So in this study, it's an open-label study, involved 35 patients with Alzheimer's disease. They showed that there's improvement in neuropsychological scores for up to 3 months, as shown in the figure A and B here, comparing a pre-stimulation to up to 3 months post-stimulation, and also the memory and verbal factors. And there are no major side effects. Of course, the caution here is that this is an entire open-label study, so there is no sham control study published so far. So to summarize this talk, so transcranial ultrasound stimulation is a safe method for non-invasive modulation in human subjects. Using the protocol of theta burst ultrasound, we can increase cortical excitability for at least 30 minutes. It is relatively efficient because it only requires about 80 seconds of stimulation, where the high efficacy, about 40% increase in cortical excitability, and the study we found reliable in 14 out of 15 subjects. The effects are preserved in older subjects and in patient with Parkinson's disease on medication. And we can target the deep brain structures, which is the advantage, and they can potentially be developed as a method for non-invasive deep brain stimulation. So overall, I think it's promising. It's still a very young area, novel area to investigate, but it's a novel non-invasive neuromodulation method for neurological and psychiatric disorder, including diseases such as Parkinson's disease and Alzheimer's disease. Okay, perfect. The last I'd like to is to acknowledge a few of the collaborators. So many of the study I show you is in collaboration with Dr. Andres Lozano, who's a neurosurgeon at our institution, and want to acknowledge many past lab members and current lab members that contribute to the work. I don't have time to mention them individually, but the one in bold are the work that I mentioned in this talk. Well, thank you very much, and I'm happy to take questions.
Thank you very much indeed to Dr. Pasquale-Leone and Dr. Chen for really stimulating and interesting talks. They were purposely kept brief so that we've got plenty of opportunity to freewheel over the next hour or so and discuss the things that that sort of strike both us as a panel and our audience members. Maybe what we could do is spend the first time, the first part of this hour or so, talking as a round table and coming up with some thoughts and ideas between ourselves about the content that we've heard, and then afterwards we'll turn to some of the questions coming from the audience. So once again, many thanks indeed. Lots and lots of material to chew over. And I wonder whether we can sort of structure our discussions, at least as a vague idea to start off with. It may well take another course, but we can start with sort of small scale mechanistic stuff and then gradually work towards thinking about bigger issues to do with clinical trials and the future. If that's okay. And we've got Dr. Patel here as well, the four of us. And I mean, I guess to kick things off, what we've got nicely here are two broad areas of technique. We've got the sort of tried and tested electromagnetic stimulation techniques, and we've got the more novel ultrasound stimulation techniques. So should we think a little bit about the mechanisms of each of these two and how they may be working, I guess, both at the at the level of neuronal plasticity and the sort of things we might see in the immediate aftermath on behavior and EEG measures, but also maybe what they're doing to the underlying brain pathology, if indeed they are having effects at the level of amyloid, tau, inflammatory markers, and so forth. So maybe, Dr. Pasqualeoni, we could kick off with you. Do you think that we understand really well the mechanisms of TMS and electrical stimulation in Alzheimer's people?
That's a very good question and an easy one to answer. The answer is no. So I think one of the realities we need to face is that while appealing to translate these techniques to humans in the goal to try to improve their suffering and allay their suffering, one of the consequences of that relatively easy translation is that we've left behind a sort of hole of detailed understanding of the mechanisms, the kind of work that would traditionally have been done in animal studies, ultimately leading up to the human translation. And we find ourselves in the need to really fill in those gaps of knowledge if we want to really take these techniques to the next level. That can be in part done with carefully crafted mechanistic assessments in humans, but I think more basic studies of the nature that can be done in vitro preparation in animal studies are going to be needed. I think if we don't do that, at best what we have with human studies right now are sound hypotheses that may be partly true, but that might not fully capture the full extent of the mechanistic impact that these techniques have. To address one aspect of the question you raise, if I may, we have the ability, of course, to start looking at some of the biomarkers and pathological cascades, not just the effects on neurophysiology or behavior, but also things like microglia activation, inflammatory cascades and inflammatory biomarkers, amyloid and tau. And it is encouraging that the very early studies that have been conducted that start to look at these phenomena do show an effect, not just on the behavior, but also on the pathological cascades in these illnesses, specifically in Alzheimer's disease. And so I think we start to have the tools to query mechanistic questions carefully in humans, but we do need to seriously explore basic studies to be able to really fully realize the potential of these techniques.
Thank you. That's great. Dr. Chen, with the newer field of transcranial ultrasound stimulation, what do you think we can learn from the experiences of TMS and electrical stimulation over the past 20, 30 years, and the ups and downs in the road, some of the mistakes that may have been made along the way, and how can we learn from those to save time, bring more rapid bench to bedside translation, but also understand which are the mechanistic things that are important here and which are the mechanistic things that we actually don't need to worry about because they're rare element.
Right. So first of all, I would say I completely agree with Alvaro just said. We need to understand the mechanisms involved as much as we can, maybe combining both human studies, in vitro study, in vivo animal studies. Now, I would say, well, we may not completely understand what TMS does, well, even much less what ultrasound neuromodulation does. So, as I mentioned, there are various hypotheses as to how it works. That may cause thermal effect, like bubble formation, membrane deformation, opening up of mechanosensitive ion channels. So often maybe a combination of these. So we have some idea perhaps from animal studies, but we still don't really know exactly in human subjects what is exactly the mechanisms of it. So I think you also mentioned earlier, Chris, like the plasticity effect. So, for example, we introduced a method using a theta burst ultrasound to induce plasticity. So in a sense, we also try to investigate a bit more what's the mechanism. So recently we did a study using pharmacology, basically giving drugs to normal subject, which is the technique used already in TMS or TDCS study. And the findings suggest that it may involve a kind of long-term potentiality because it's, for example, blocked by an NMDA receptor blocker, dextromethorphan can administer to normal subjects, or a calcium channel blocker, which is also involved in kind of LDP function. Now, having said that, all these data we get in human is still indirect evidence. It's not a direct proof. I mean, it's kind of consistent with the, but it's not really direct proof. So I think, as Alvaro said, we need a combination of human studies and also basic animal studies, and also kind of even slough sizes work to really best understand, I think, the underlying mechanism to see how we could take these methods forward. And I also very much agree with Alvaro earlier that, for example, in Alzheimer's disease, we can not only look at, for example, use TMS, look at close guidability, but also use, say, PET imaging, for example, look at amyloid or tau deposits, a range of biomarkers that we could potentially use. And example in my talk, Parkinson's disease, one example, there's a well-known biomarker, which is increased beta oscillation in the basal ganglia. So I think we should combine this with, other biomarkers that are available to, which will be different, of course, from one disease to another disease. I think as a non-invasive brain stimulation, very much like TMS or TDCS, as a treatment, I think, say, one session is probably not going to have a long-lasting effect. It's sort of like DBS, that we implant the electrode, we're going to stimulate continuously. So I think we're going to have to work out some protocols that, doing additive pattern. We still don't know exactly what is the best protocol, what is the best pattern to use. But I think this is, again, something that we need to work on, maybe, again, combining the knowledge we will hopefully gain on the underlying mechanism, combining both human and animal studies to try to devise what is the best, as best we can do, the protocol. Because as you know, ultra, just even like repetitive TMS, or there is just many parameters. There's a big parameter space to investigate. It's virtually impossible to investigate everything. So we need some guidance as to how to take it forward. But having said that, I think we can learn, as you mentioned, from what has been done already, say TMS or TDCS, other non-invasive method, what works now. So to try to kind of push this forward.
Yeah, thank you. Vanessa, did you have any comments on
Yes. Well, thank you very much to both speakers for their excellent presentation. It's a pleasure to have you participate in this event. As the clinical manager of the memory unit, the biggest challenge is the application of this kind of technique in the real world. So I would like to hear the expert opinion on the clinical potential of these techniques in daily clinical practice. How, when, why we can use this technique in our clinical practice. So perhaps I want to hear their opinion, and I think that they could explain us how to do it in a correct way, in a real way.
So if I may just get us started, thank you, Vanessa, and Chris for the question. I think that one of the appeals of these techniques, as I mentioned briefly before, is that because of their non-invasive nature, they are reasonable things to try in humans, provided there is a clear hypothesis and a careful assessment of the effects, so that we don't simply sort of bank on serendipity, but that we rather set things up to do a clinically informed sort of reverse engineering so that we can understand and move the field forward. That said, I do think they lend themselves to the clinical application under such careful setups. I do worry about the appeal of more broad spread or very broad spread adoption of these techniques, such that ultimately potentially side effects or lack of efficacy is confronted when in fact one could have helped patients in a sensible, ethically appropriate way. I think it requires first enough controlled evidence to be able to create the foundation for such clinical application, and then an appropriate disclosure to the patients so that they understand what we are targeting, what we know and don't know, and are empowered to make the appropriate diagnosis. It requires, at the end of the day, an appropriately laid out a priori protocol so that one is not being driven by the understandable hope and desire from patients to try something that may help with what otherwise can be a very disabling situation and disease. So I think appropriately, carefully spelled out and controlled clinical application is possible, but I would worry about a very wide breadth spread and uncontrolled clinical application that would generate hope that is not sufficiently founded and supported by evidence to date.
Yeah, that's a really, really important point, because we can do harm not only by causing a lesion, but also by not doing meeting the hopes and expectations of the patient. Yeah, that's really valuable. We've sort of had slightly the opposite end of the spectrum in ultrasound in the very earliest days that we've lived through over the last 5 years or so, where I think groups have been cautious about trying to explore the parameter space because of a couple of early reports of possible damage in animal preparations that slightly held things back a bit, and yet we don't really know how far we can push the envelope to get beyond the relatively small effect sizes that we're seeing, certainly in some brain regions at the moment. And I wonder, Dr. Chen, whether you've got any thoughts about that, about I guess how we balance exploring this very vast parameter space that you've already mentioned, and not holding back so that we don't end up disappointing, as Dr. Pascual-Leon has mentioned already. So, there's obviously a role of interaction here with regulatory bodies as well, which needs to be thought about, and I'm sure that ultrasound can learn from the way that the TMS field has had to do that over the past couple of decades. So some thoughts on regulation, boundary pushing, side effects, and efficacy.
Okay,
Robert.
Can you hear me? Okay, so for some reason I'm not sure why the video has stopped there. Okay, you can hear me okay, right? Okay, great, thank you. So first, I think the question of the clinical utility, I think there is a very good potential clinical utility of ultrasound, because we can stimulate the deep brain regions, which cannot do it with other methods. So it can be developed as a non-invasive deep brain stimulation. So I think, so deep brain stimulation is very effective in Parkinson's disease. I think we all know. It's still not an establishment with Alzheimer's. It's very effective in Parkinson's disease. But even it's very effective, only a very small proportion of the patient actually undergo this procedure. Because first of all, many patients actually, even we estimate like 20% of patients who want to do it, only like 2% actually. So eligible to go through it, only 2% actually will go through it. Many because don't have side effect, people maybe also very expensive. So I think if we can develop a non-invasive deep brain stimulation, it would be much more accessible to a much wider population of patients who may not be surgical candidates who do not want to undergo surgery. So I think there is a lot of potential for this technique. But what Chris mentioned earlier is how do we push it forward? Yeah, as you mentioned, many of the studies done is based on what's currently the FDA guideline. Unfortunately, it is based on diagnostic ultrasound guideline. So there really is no guideline for a like a neuromodulation. But so I think that most of people use are also very, in a sense, very conservative parameters. So the pressure that we build is much lower than I think that will cause tissue that, which is good in a sense. When you start, we want to be safe, which is the most important aspect. But I think that we need to do is, as a field, maybe forward, similar to what TMS has, for example, a safety guidelines that have been published and people follow. So I think as a group, we need to come together with, people who do this, with experts in physics, maybe with regulatory authorities, to come up with, I think, some guidelines that people, feel safe to continue to explore. So I think we need to do is, again, have some threshold. So we need to balance between, of course, advancing the technology and safety. And the safety is obviously very, very important. But I think right now we are not really pushing enough. I think all the products are very, very low intense. I think they're far from, causing any damage. So, but I think we need to maybe as a group come up with something like the TMS guideline, which is widely quoted and used. Maybe also, work together with regulatory authority like the FDA, other authorities, to come up, I think, with some parameters everyone can agree on, how to push it forward. But individually in each group, I think people are gradually, using different parameters, try to push it forward. I think, but it would be helpful to the field to have, some consensus. So how do we can push it forward?
Yeah, that's really helpful. Thank you. I'm just going to pull it back a little bit to the mechanistic space again, as we started out with, because I've had a question from Michael Ewers, who's in the audience. This is to Dr. Pasquale, but I think probably can be answered by both, because there's a question about what frequency range you consider to be preferable for brain stimulation in Alzheimer's disease. And what does the panel think about the recent astonishing findings, he says, of gamma stimulation via tonal light in animal models of amyloid and in humans? So some chat about different frequencies, what we should be targeting.
Yeah, thank you for that question. It's a great question. If you allow me to take one step back before aiming to give a number, I think it's important to realize that the technique applied, the methodology applied for neuromodulation will have, as we were discussing, different mechanisms of action. And so therefore, the frequency of stimulation of TACS, transcranial alternating current stimulation, or TMS, or ultrasound, or any number of other neuromodulations will have a very different meaning. So I think don't take what we learn about frequency in one technology, one application, to be true for other technologies. I think that would be misleading and the wrong conclusion, among other things, because the meaning of frequency numbers in different techniques effectively mean something different. We're not talking about the same frequency of stimulation when we apply alternating current than when we apply TMS. Even if the number is the same, effectively we're doing something different in terms of the neurophysiologic signature. With that caveat in mind, what we have learned is that there are different frequencies of stimulation that, because of the nature of the oscillatory activity in the brain, resonate and train frequencies of brain activity, and in doing so can lead to lasting plasticity-mediated effects. That's why I was talking about spatiotemporal signatures. We want to target not just different locations, we want to target a given node of activity, a given location in the brain at the correct, quote, frequency, at the correct temporal domain to be able to resonate with that given activity. The implication of that is that for different nodes and different networks in the brain, the quote correct frequency is likely going to be different. In fact, we have good evidence to support that claim. The second implication is that there might be, as indeed there are, individual differences, so that the same oscillatory frequency for a given effect may need to be tuned slightly for different individuals. A lot of that individualization, personalization work hasn't happened. But what we have come to learn is that there are specific frequencies of activity, as the question was asking, that particularly drive hippocampal networks. And in doing so, that has been done with optogenetics first by Li Hui Tsai's team, and subsequently been done by them and others with sensory stimulation. And what we've learned from that very nice animal work is that one can demonstrate a loss of gamma frequency range activity in the hippocampal structures in animal models of Alzheimer's disease, and in reintroducing that, restoring that activity in the animal models, it not only leads to a behavioral effect, but to a pathologically beneficial effect with activation of microglia and reduction of amyloid and tau depositions. Sensory stimulation, visual, tactile, and auditory, ideally combined, remarkably achieves the same effect in the animal models. And I mentioned at the beginning of my talk that Cognito, a company that has been founded on the basis of that work, is now conducting a pivotal study in humans, trying to do the same in humans. Similar work inducing 40 hertz stimulation, I mentioned briefly, with transcranial alternating current stimulation, appears to have also beneficial effects in memory network in humans, and pilot work with Emiliano Santernecchi and others shows that it leads to a reduction in amyloid deposition and tau in humans. Very exciting, very preliminary work. So there might be something rather unique to the fact that memory networks in the subcortical-cortical relation have a coupling of gamma 40 hertz and theta activity, and that coupling of theta gamma activity appears to be particularly crucial. There is a lot of evidence to that and a lot of evidence to unpack. But again, let me emphasize that might be true for the memory network. I think it is, but that for prefrontal executive function, for visuospatial functions, for motor domains, different frequencies apply.
Yeah, thank you. That's so interesting. And Dr. Chen, taking it to the work in ultrasound, I mean, first of all, it might just be worth clarifying for the audience that it's very unlikely to be anything wobbling at 500 kilohertz that's actually doing anything effective to neurons. So, you know, those are way above the sort of frequency of anything biological that normally happens in the brain. So maybe you could just explain how it is that the ultrasound has a biological effect, and then maybe talk again about particular frequency domains of interest. And I was interested particularly in your studies in PD, whether you had any influence on beta in the motor cortex, whether you've measured that using EEG.
Right. Yeah. So the first question, I think, so ultrasound. So there are different frequency that we can, in the parameter. So one is called the fundamental frequency. Fundamental frequency is how frequent fastest ultrasound we apply. So typically in human subject, most studies use roughly 250 to 500 kilohertz. Now, these are chosen mainly, there's a balance between absorption by the skull and how focal the ultrasound is. So the higher the frequency, the more focal the ultrasound, but it's get more absorption by the skull. So to simulate human subject, most investigative people think that maybe 200 to 500 kilohertz is a balance between how much you get through the skull and the focality of the ultrasound. Having said that, this is a very high frequency. 500 kilohertz is not the kind of the normal frequency of a neuron that's oscillating. Now, but we can apply this in bursts of, say, 40 hertz or 5 hertz, for example. So in our study for you, we call it theta burst ultrasound. So we apply these 500 kilohertz in 5 hertz bursts. So the reason, of course, theta burst is that theta burst stimulation is a known way to induce LTP plasticity in the hippocampus by using, say, 5 hertz electrical stimulation. So there is some way of using ultrasound to mimic of the natural frequency, repeated at 40 hertz, for example. But I think, as Alvaro said, what is a optimal frequency? I think it really depends on what condition you are treating, is Alzheimer's versus Parkinson or other condition, and even what brain area that you are stimulating. And also, I think, as Eric mentioned, I think each method is different. So a optimal frequency for electrical stimulation may not be the same for somatosensory stimulation or for ultrasound stimulation. I think because against the mechanisms of these, all these methods are quite different. So so I think we still need to explore these, say we apply 5 hertz ultrasound versus 40 hertz. What is the underlying mechanism? Are we causing that plasticity? Are we increasing or decreasing excitability, for example? So I think answer a question is, we haven't looked at beta oscillation. Now, in our study, we have not yet measured EEG. So the question is, say, if we apply certain parameter of ultrasound, could we reduce, say, we thought we abnormal beta oscillation, say in this Parkinson patient in using EEG, right? But so far we haven't done that, but we are actively pursuing studies that mention that we are trying to apply the ultrasound actually to the basal ganglia. And we have patients implanted with a DPS electrode that we can record the signal with a Medtronic Percept device. So we're actually pursuing this if we can. So actually there's several studies. The one study is if we can stimulate the motor cortex, for example, and change the basal ganglia beta oscillation, because we think that this may be a biomarker of what may be an effective parameter. And another study, we're actually trying to stimulate directly the basal ganglia, say we electrode implanted in the subforamen nucleus, we are trying to actually stimulate the subforamen nucleus to see if we can actually to reduce the abnormal beta oscillation. But unfortunately, these studies are ongoing, so I don't have any results to show at this time. But I think that the issue of frequency is obviously very important. As Alvin know, we know that different brain functions operates at different frequency, and then different diseases have often, pathological oscillation. Some may be increased, some may be decreased. But I think we need to do is maybe get some, as Chris, you mentioned earlier, get some reliable kind of markers. If we know that, for example, Parkinson's disease, this beta oscillation is increased, we can look at this as a biomarker. The same thing in Alzheimer's disease. So EEG also high frequency is deficient. We can use it as a biomarker. So I think that we can use the frequency as a biomarker and also as a frequency of stimulation. But there are many caveats I mentioned already, like different location, different disease might be different, and different stimulation modality might also be different.
Yeah, absolutely. Okay, great. Well, I think, as I understand it, that Dr. Boada has a question. Is that right, Dr. Boada? Ultimate host.
Hello, thank you, Chris, for the opportunity to talk with Dr. Robert Shane and Álvaro Pasqualione. Thank you. Thank you for this excellent and exciting talk, because I believe that we are learning so much, but the most important is how we don't know these other kinds of techniques to be used in clinical area. In clinical area. Everyone that you are talking seems that at the first it's more personalized and functionalized treatments. It's more focal. You are talking about the frequency. Every one of the techniques is completely different from the other, and offer the opportunity to understand much. We need to understand much and more much the functionality of the networks in the brain, because it's working in another sense and in other ways that pharmacology. We are very handy to be involved in experimental drugs for the Alzheimer's disease, my cognitive impairment, Parkinson's disease, every one of neurodegenerative disease and other diseases, and seems too easy for us. But in the globality, when we are talking about drugs, we are talking about 1,000 individuals involved for one experiment, 2,000 individuals to involve in one experiment. For how long? 12 months, 18 months, 24 months. And now we have changed the scenario completely. It's more reduced the numbers in the experimental. It's more concrete aspects for stimulate or depress. And I believe that it's offer really an huge opportunities to match both strategies, because the standard strategies in our goal is drugs. It's pills, infusions, but that is completely changing. We need to understand more. We need to be very conservative, very cautious into prescribe one other treatment for facilitate the stimulation, because we are talking about the plasticity, the brain stimulation, to reduce the dose. And it's really enormous, this new scenario that we have in the hands. Maybe we need more clinical trials, very well designed. It was very difficult to define very well the main objective, include another marker that is not that we are usually working with, because we are working with neuroinflammatory markers. Maybe we modify all the environment from the neurons and the circuits, but we are talking about the beta and tau, and here I don't know. And our goal is changing little by little, but we need to be focused on this kind of the therapies to implement the benefits for the patients, to personalize this treatment and understand more or less. That is not a question, of course. That is my gratitude for understand how is our future. How is our future? And as a medical director of ACE, our intention is to collaborate. We need more patients, very well defined, understand very well the phenotype, to follow these patients, to include another markers that could be more functional markers, to include all your knowledge in our practice clinical. And I believe we are open bridge in order to work together to offer the best opportunities for our patients, and also for us as a clinicians and as researchers. I don't know, that it's very global, but both you, Robert, and Álvaro are talking about to collaborate, design clinical trials, using the very strong and robust methodology to find very strong results. And that is our style of life in Fundación ACE. Thank you, Chris, for offering this opportunity, and Vanessa, because really I am excited for this talk, because offer a new future, is a big window to understand more and more the brain.
Thank you for those wonderful comments. There's lots to unpack in there, but maybe some thoughts about trial size and personalized stimulation. So, I mean, do we foresee a future where we're going to have, multi-center, multi-country trials with thousands of patients and lots of different input and output variables?
So, if I may, Chris, I think that's very important, and I think it's one of the many really important points that Dr. Boada was making. The promise of these techniques is the capacity to personalize the intervention, right? To target an intervention to the disabilities, to the problems that a given patient presents. That requires I like to talk about a clinic-inspired reverse engineering, where we need to start by a careful phenotyping of the patient. To me, that is the number one thing. Carefully describe, carefully assess the presentation, the manifestation, the disabilities of the patient. Ultimately, empower the patients to tell us what are the symptoms and the disabilities they need and would like to have addressed. The number two thing, I think we've echoed it a number of times, leading by your good questions about mechanistic, is the number two thing. We need to capture a carefully defined hypothesis that is mechanistic, and we need to look at the results as how much of a clinical benefit is accounted for by that hypothesis, by that mechanism. Oftentimes we say, this is what we think we're going to do. This is what we see behaviorally. Hence, we have shown that mechanistic bridge is there. Not so. You need to design your experiments and analyze your findings in a different way, right? So the second thing is to embed in that analysis of the clinical outcomes, the mechanistic questions. And that requires, as Dr. Boada was saying, a carefully designed protocol. But in order to really move the field forward, the number three thing that I think we need to do is be able to capture the data in such a way that they can be placed in a shared database, so that together, as a global effort, we get increasingly rich data sets that allow us to really ask mechanistic questions and move the field forward. It's an open and very explicit call for open science, where we share the results and benefit from the opportunity afforded by patients that give us the opportunity to study them while we try to help them. In order to fully derive benefit from that generous gift, we need to capture the data carefully, and we need to share them with others, combine them with others, to be able to really move the field forward. If we're able to do those three things, I think we will help patients while we advance the field substantially.
The negative results as well as the positive results.
Absolutely.
Dr. Chen, some thoughts?
Yeah. So I just thank you, Dr. Boada, for your comment. I think I just want to address one point, which I think very important. You mentioned the personalization. So right now we just often use the same parameters for everyone. As you know, in many, say, for the repetitive TMS study, maybe overall there's a benefit that work for somebody, doesn't work for another person. We don't actually have a good understanding why this, say, particular protocol works in someone and not work in another person. So I think in the future, one possibility is we can personalize a more personalized protocol. For example, if we have some kind of biomarker, maybe whether it's a clinical measure or it is EEG or functional MRI, that could tell us, say, this for this particular subject, for this particular type of symptom, maybe this set of parameters will work. So we have maybe several we can test. So maybe we can personalize it to the Alfred mentioned particular symptom, but also maybe even that two individuals are very similar, but maybe they need, because the brain is different, they need different parameters. So I think one thing perhaps going forward is that, because as we all know, non-invasive has very high variability. So it works in somebody that well, if we can understand it a bit more, and if we have or able to develop some reliable markers as to tell us which parameters going to work in this particular subject or group of subject, I think this will also push the field forward.
Yeah, thank you. Well, that leads into a question from one of our audience, actually. I'm not sure how easy it is going to be to answer, but Christina Paga says, thank you so much for the talks. My question is for both speakers. Have you found any sex-related different responses to the various treatments? I guess it depends what the outcome measures are. But is there anything to say specifically with that? As we know, of course, Alzheimer's disease has a particular impact upon women.
Yeah, I can submit. So in our own study, we actually did try to look at some sex differences. We haven't, we actually look at it, but we haven't found any. But having said that, our sample size is very small. I mean, it's all preliminary studies. We're probably not powered to look at that. But I completely agree. I mean, this is a very important measure. I think, as Alfred mentioned, going forward, I mean, our data should be public. I think that should also be should know the sex of the subject, so that maybe, with a larger data set, I think, hopefully we can have, look at some of these effects. But I do agree that this is a very important topic that really should be examined.
I completely share that opinion too. It's a very important question for the very reasons Christina raises, right? There is a difference in the manifestation of the disease. There is presumably some differences in the pathophysiology. What are they, and how can they be modified by the stimulation? We know from transcranial current stimulation and from transcranial magnetic stimulation studies that particularly interhemispheric differences in excitability and connectivity between the hemispheres show gender-related differences, sex-related differences. Is that of any relevance for the therapeutic effects in neurodegenerative diseases and Alzheimer in particular? We don't know. And in order to really explore it, going back to what we were saying, we need the measures and we need the large enough N, like Robert was saying, to be able to power those questions appropriately and go beyond hand waviness to really capture this. One last point is that we would need also clear information and detailed information about pharmacology that the patients are on, because there is a likely interaction between the pharmacologic treatments patients take and the effects of the stimulation, and therefore the potential benefit or lack thereof. So again, a very explicit call for global collaborations with large data sets, so that those questions can be systematically explored.
Thank you.
Yeah, thank you. Thanks so much. Dr. Patel, I think you have a question.
Well, in relation in what Dr. Aguada commented before, and thinking of offering our patient all the best treatment opportunities under the best scientific and professional support, I have this question. In last year, the knowledge about non-invasive brain stimulation technique is growing exponentially, and the need for specific and regular training on this technique is being exposed. How do you think this training should be to guarantee its correct use, and for us, for the professional that we want to use this technique, how we have to train in this technique?
Great question.
So Vanessa, you actually find me right now in Boston at a sort of gathering that Shan Siddiqui has put together with Mike Fox and others to talk about, quote, a new specialty in brain stimulation techniques, cross-sectionally across disciplines, right? Because psychiatry, neurology, neurosurgery, rehabilitation medicine, neurophysiology, there is a common cross-sectional aspect of these techniques we're talking about. I personally think that what we need are centers of excellence, similar to what has been developed in, for example, in the context of epilepsy, comprehensive centers that bring together team expertise in these domains so that jointly those experts can have not a barrier to entry for others, but rather a level of expertise that allows the challenging things and challenging questions we're talking about. And in the setting of such centers of expertise, specific competences need to be acquired by trainees. It takes time. It's deceivingly simple. The International Federation of Clinical Neurophysiology has put out competencies for transcranial magnetic stimulation, for transcranial current stimulation. I think we need to do that effort for all the methods and techniques we're talking about and provide centers where the acquisition of such expertise can be really developed in targeted specific fellowship training. And I think that would move the field forward substantially without creating barriers to others. The risk, if I may, one last point, if we don't do that, is that some of these techniques are deceivingly simple, and it's deceivingly being the operating word. And so if people want to apply it, patients ask for it, there is hope associated with it. But if we don't ensure that appropriate care is taken in how it's applied, again, I think it's not only potentially non-effective, but in fact dangerous. And so I think we owe it to our patients to have the appropriate training and competency ensured. So, anyway.
Okay.
Thank you. Dr. Chen, some thoughts about that? And I wonder whether you might also like to comment on, because as is often is talked in, maybe less in the world of TMS, but certainly in ultrasound and also in temporal interference, this can be done at home. You know, people can just stick something on their head and lie in bed at night with it, and it's going to make all their memories suddenly much stronger and last forever. Thoughts about training for ultrasound, maybe feeling a little bit far in the future, but what do you think about how much these techniques demand very careful, precise administration, and how are we going to move to that, to scaling them up to the enormous number of people who could potentially benefit from them out in the real world?
Yes. So first of all, I completely agree with Alvaro just said. I think, we really need is some standards for practitioners of these area. People should have some standard sort of training. I said the IFCN, International Clinical Physiology, has put out some standards for TMS and TDCS, and as Alfred mentioned, some places may have looking forward to some sort of like certification for so like neuromodulation technique, for example. I think this is the direction that we should move to. I say I don't repeat what I said already. I just completely agree with him. But I think Chris, what mentioned about ultrasound is a little. This is a very young field in the sense that people, there are actually not that many labs doing in human studies. But I think it is a complex procedure, particularly if, say, you want to target a deeper brain region, because the skull is a barrier and it deflects. So usually we have to do individual brain MRI or even CT scan and do modeling. So it is not really, I think, something that someone can buy something on Amazon and kind of do it at home. I don't think that is at least as we stand, is really an option at this point. But I think we need to, as a field, because it's a very young field, but I think we need, again, develop basic standards that people are trained to know what to do, and particularly make it everything is safe. Because yes, your ultrasound even if high intensity, you can actually cause a lesion, which is actually being used clinically at this point. So one really needs to know, you need to know what they're doing. So I think we need complete agree that we need standards, and hopefully, by like international society or some regulatory authorities that has some that can be at least can be adhered to, that can be enforced in some way in certain countries. So so in the future, but I think this is a young field. I think we need probably a little bit more data before we can develop this guideline. But I think that for kind of, if you like, quote unquote home use, I think is a lot of this, I think, is transcranial electrical stimulation techniques. You can probably buy a device online and kind of do it yourself if you like. So actually, I think a number of years ago, I actually attended some meetings to try to actually address this issue as well. So we generally think that this is something that should not be done. I think should be regulated. Is again, it's a regulatory issue. Are these medical devices or the devices to improve your gaming ability, for example, right? So but overall, I do think that, especially ultrasound, I think we need to have some standards and guidelines. Hopefully, will be developed in the next few years.
Great, good thoughts. So another question from an audience member, Michael. An anonymous questioner is asking about what's your opinion about the use of non-invasive brain stimulation in preventing MCI to dementia transition? I guess this could be a broader question about efficacy at different stages of the neurodegenerative process, from potentially prevention, in healthy older people, through to the prevention of progression once a pathological seed has already been sown in the brain, so to speak. So could we have some thoughts about that from you both? Do we really know where is the money, or should we just be trying everywhere?
That's another very good question. I think we should not be just trying everywhere. I think we should come up with a sensible hypothesis, or various sensible hypotheses to explore in a carefully designed approach. That said, I think such hypotheses can be formulated. It is likely that the process of progression from mild cognitive impairment to dementia is not a simple one. There are many factors that can determine that, obviously. One such factor, broadly speaking, has to do with cognitive reserve, or with cognitive resilience and resistance to the pathology. And for both of those, there are hypotheses that have been put forward, anchored by data from animal models and others, including human studies of neuroimaging, identifying brain networks that appear to be particularly relevant for reserve and resilience. There is an NIH collaboratory that I had the pleasure of being part of that came up with a literally call for action on the basis of such findings to explore questions like the present question asks. Can we enhance reserve and resilience in meaningful ways that translate to clinically relevant applications? I happen to be in the camp that believes that is possible, but it does require the kind of large-scale collaboration with sharing of data that would allow us to explore this properly. It also requires carefully designed studies, including basic questions to be answered, so that we're not just putting coils or ultrasound emitters in different locations and see whether serendipity strikes and we find something of benefit. So it's a very good question. I think it's a question worth exploring, but I think given the complexity of the processes involved, a carefully defined target and a demonstration of target engagement for a potential effect, I think is essential.
Thank you so much, Dr. Chen. Any insights from you? And I guess there's perhaps a much longer pedigree through DBS of stimulating at different stages of the development of Parkinson's disease. So maybe we have some things to learn about the timeline from that history.
Yes, so I think that if we want to delay or prevent conversion from MCI to LCI, I think it's a reasonable target to do. But as Alvaro mentioned, that it is maybe very different from treating someone with established Alzheimer's disease, for example. So we need to understand the kind of underlying neurobiology of this, because maybe more, for example, in MCI, maybe we could boost the reserve, and maybe that might help. So I think we need to, so I think it's a reasonable target for non-invasive brain stimulation, but we need to understand, have a good hypothesis, as Alvaro mentioned, that what are we actually targeting, and then it will, I think, may be different stages of disease. So as you mentioned, in Parkinson's, again, there is, for example, there are people who have, for example, REM behavior disorder thought to be very high risk of developing Parkinson's. They don't actually have Parkinson's. So there are, already some clinical trial, not that I know of, using non-invasive brain stimulation, though, to try to target this group of patient or subject. So, but again, this is very different, say, in Parkinson's, from someone who has very early motor functions versus someone maybe very advanced Parkinson's. So I think these are all very different, even though maybe the same disease. These are very different stages. I think we need to understand the underlying neurobiology and have a rationale and hypothesis-based treatment. I think they probably won't be the same treatment for all these different stages of Parkinson, and I think the same for Alzheimer's disease.
Wonderful. Well, thank you so much. I think we probably need to wrap up there, actually. We've got to the top of the hour very quickly with fascinating discussion, which ranged really broadly. But I think there were a few particular themes that maybe we could just summarize with to conclude. And one of those that's come up is understanding the neurobiology. So, we do need to know the mechanisms in order to generate the next thing, which has come up a lot, which is hypothesis-led science. So we have to understand the mechanisms to generate the hypotheses so that we can then begin to explore that parameter space in a principled way. But the only way we can really do that effectively and efficiently is to do it through collaboration across centers and across countries to get the numbers of patients and the numbers of scientists that we need to not waste time in getting these extremely hopeful therapies to our patients. And of course, the final big theme is that of patient-centered or personalized treatment, which I think is still, a way in the future, but is definitely the goal to which we're all aiming. And I really look forward to the next 10 years worth of research in this space, because I think it's going to be absolutely revolutionary. So thank you very much indeed again, Dr. Pasquale-Leone, Dr. Chen, for your inputs. And if I may thank also Ace Alzheimer Center for hosting this session, which has been incredibly enjoyable and informative. And I will hand back over to Dr. Pitel to close the session. Thank you very much indeed.
Thanks, Dr. Water, and thank you very much to the speaker who has so brilliantly guided this final section. I would like to thank the support of our sponsor and to the audience, of course. Thank you all for being here today. And it's my pleasure to announce that the Global Research Summit will come back on 2025 with more knowledge to share. But before that, we want to invite you to join the Barcelona-Pittsburgh Biennial Conference, which will be held next year from the 15th to the 17th May 2024. Barcelona-Pittsburgh is a high-quality conference that brings together panelists of recognized international scientific prestige and creates an interactive space related to neuroscience. As you see, amazing things will happen during the next couple of years. And we'll be happy to meet you here in Barcelona next spring. Until then, stay safe and see you very, very soon. Bye. Thank you. Thank you for all of you.
Thank you.
Thank you. Bye.
Thank you so much.
Thank you so much.
Thank you so much. Thank you so much.
Thank you very much indeed,
Bye.
everybody. Really lovely
Bye.
discussions and talks. Thanks for your time.